Hello, welcome to Cardio Flash College, a place to learn cardiology with flash animations. Today we continue with our weekly section Flash Code, a place to explore the world of acute coronary syndromes and primary angioplasties. Let's begin. This week we have a male of 55 years of age, smoker, without cardiovascular risk factors or any background of interest. He arrives at ER because of dyspnea of small efforts of 12 hours of evolution after an episode of prolonged chest pain. He was diagnosed by the emergency care services of an evolved ST segment elevation myocardial infarction complicated with an acute heart failure. This is the electrocardiogram of our patient. As you can see, it is evident the existence of changes on the ventricular repolarization. These alterations express as elevations or descents of the ST segment in some leads, and they suggest an acute myocardial lesion. Could you identify these disturbances? That's it! In this electrocardiogram, we have an elevation of the ST segment from V1 to V6. Moreover, there are clear QS complexes on all precordial leads and also on high lateral leads. All this suggests that there is an extensive STEMI in the anterolateral wall, sufficiently evolved to produce extensive transmural myocardial necrosis. This is the chest X-ray of our patient. As you can see, there is a clear distribution of bronchovascular weft, pulmonary congestion, and an increase of cardiothoracic index. This, in the context of an evolved transmural infarction, suggests that myocardial necrosis has been extensive enough to generate ventricular dysfunction, and thus heart failure. But what clinical relevance does this have? Very simple. ST segment elevation myocardial infarction is the regular clinical manifestation of a complete blockage of a coronary artery and constitutes a cardiological emergency where every second counts. In this way, our main objective is to open the artery as soon as possible, whether it is using fibrinolysis or primary angioplasty. In this case, cardiac catheterization was made. As you can see, right coronary artery is diffusely ill and also presents an occlusion of its middle segment. The extensive net of collateral branches suggests that the occlusion is chronic and therefore it does not seem responsible for the current event. Let's take a look at the left coronary tree. As you can see, there is a complete occlusion of the anterior descending artery at its proximal segment prior to the origin of the first diagonal branch. This explains the electrocardiogram changes described previously in the anterior and lateral walls. Now we know where the obstruction is and we only need to treat it. First thing to do is to pass an angioplasty guide wire through the closure. Sometimes, as in this case, passing the guide wire partially opens the artery and allows us to see part of the distal bed. In this case, the next step was to implant a stent on the blockage zone. This props the artery and returns blood flow. And this is the final result. As you can see, we have recovered the blood flow of the artery after implanting the stent, obtaining a good angiographic outcome and without pre-procedure complications. Finally, despite opening the artery, QS complexes are still present because myocardial necrosis is not reversible. For this reason, coronary revascularization after a myocardial infarction of more than 12 hours of evolution is usually justified not only by its ischemia time, but also by the clinical, electrical, and hemodynamic instability of the patient. With this message, our chapter ends. It has been all for today in Cardio Flash College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye!